spent considerable time yesterday laying the foundation for understanding the addict, what makes him so, how he tries to fix it himself, long before he ever comes to us. By the time he reaches us, he's a survivor. And then we're going to have to find ways of building on whatever strength he has retained. What I'm going to do today is rush very quickly through some of the research that supports the material that I gave you yesterday. I promised I would, and I intend to. One of the outstanding things about animal persuasion is the fact that they create their own worlds through the vehicle of dissociation. And in our little menu, our agenda, let me put that on for a moment. We talked about the theory, we talked about part of the role of dissociation. And now I want to share with you some of the findings about dissociation. This is where I left you yesterday. And this is where we start today. The dissociative reactions that I make reference to are operationally defined by these reactions. A trance-like state, feeling like a different person, feeling outside oneself, watching oneself like in a dream, and blackouts, memory blackouts, selective memory blackouts. As you can see, the compulsive gamblers in this did a great deal of dissociation in all of those dimensions, with a median score of about 64. The normal population, the normative group, of about 1,000. Adolescents, very little of that, and adults also very little. Tremendous differences here, 64% versus 6. And so let's look at alcoholics. Again, we find a similar kind of finding. The alcoholics, very high in dissociative reactions, particularly feeling like a different person. That seems to be the objective of many addicts. They don't like who they are. And so in their fantasies, they create someone they'd like to be, and often act out that persona. Again, the degree of dissociation is very high compared to the normative sample, both adult and adolescents. Let's look at still another addictive group, in this case, compulsive overeaters. Although not as extensive in their dissociative reactions as the alcoholics and the gamblers, who are very much the same, the overeaters show precisely the same kind of trend, being very high compared to other people who eat, of course, and dissociating while engaged in that behavior. We looked at social gamblers. The group I showed you, the adults and juveniles, were just average folk. Here we have people who are engaged in gambling as social gamblers. And we find that their dissociative scores are higher, here's the median, than the 2 and 4 and 6% that we saw among the general population. These are all adults, by the way. Compared to pathological gamblers, which are very high. And we saw that in the first chart. But the social gamblers, as we move from non-gamblers to social gamblers to problem gamblers to pathological gamblers, we find dissociative scores going up progressively and directly, highly correlated in that regard. Let's look at a sample, this is an international sample of pathological gamblers. These samples were taken in many states. This happened to be in Scotland. These come from Canada. This was a national study of alcoholics. And again, looking at the various kinds of dissociative reactions, +1, losing track of time. I added that in 1994. and it is a very, very revealing index of dissociation. If you're going to use the scales, particularly with juveniles who may or may not be in trouble, use the losing track of time dimension as well, please. Again, we find, although there's some variation from study to study, the median scores are very, very high. 75% feeling like a trance, 67% different person, and so on. These are very high scores. We then look to adolescents to see if adolescents who scored very high as pathological gamblers, to see how they compare to adult pathological gamblers. Here's a study that's done in Alberta. I was a co-director of this study, and we found that non-problem gamblers showed very low scores of dissociative reactions compared to at-risk gamblers, compared to pathological gamblers. And this transition is on the basis of SOG scores, Southeast Gambling Screen Scores. This group 3 to 4, this group 5 or more. And again, you see, as you move along from those who show few to more problems, you see more and more dissociation. As people have more problems with gambling, or with alcohol, or with food, or with work, or with sex, the degree of dissociation goes up progressively. Here we have 3 studies done, all in Canada, by the way, from 1994 to 6 to 1998. And again, we see the same kinds of correlate scores. The median scores here are relatively high. Again, there's some variation from study to study, as you'd expect, but the median is pretty solid, showing this range of scores. Now let's compare the median scores of adolescents with those of adult pathological gamblers, and I think we have a surprising story. What do you think you're going to expect? Who's going to dissociate more? The kids? Kids always dissociate more. Or the adults? Which shall it be? Make a mental note. Well, a good many of you guessed correctly if you said the adults showed more dissociation than the kids. But that really goes against the current, because studies by Ross and many others show that, and we know from watching kids in playpens, that they're dissociating all the time. And actually, dissociative scores that have been taken across population samples show that as kids get older, they lose the knack, ordinarily, of dissociation, with the exception of kids in trouble. And that's been one of my very important findings. But here we find the adults dissociate more than the kids. Almost a reversal. What's going on? What does this tell us that is so important about addicts? What does it tell us? Dissociation is a tool. It's a skill. And as one continues to practice it, it gets better, like any other skill. And so dissociation scores among the adults are higher than those among kids with equal amounts of problems with gambling. Here's the test of the theory. Again, I told you that the theory is interesting until you test it. And that's the crucible that all theories have to be subjected to see if they're worth pursuing. Do they actually test out empirically to be what we say they are philosophically, intellectually, cognitively? And in this case, indeed they do. This study was done in Canada as a reference, and I hope you'll look it up. I'm not going to spend much time on it. These are the latent variables we talk about in the theory, the predisposing factors of physiological, remember that abnormal resting arousal level, and the emotional predispositions, the early childhood feelings of inadequacy and rejection and trauma and so on. These, according to theory, lead to a need to escape through dissociation. And the vehicle that is chosen can be, in this case, gambling or drug use. And what do we find? Results, and you have this in your handouts. I'll quickly summarize them. Strong support for the applicability of Jacobs' general theory, for adolescent gamblers was obtained. The adolescent problem and pathological gamblers were found to exhibit high levels of abnormal resting states, evidence of greater emotional distress, reported greater levels of dissociation, and these arrows are the predicted direction. This is what the theory predicted. And indeed, that's exactly what we find. And the high need to escape is shown by high dissociative scores. And actually, those 5 scores I showed you earlier were collected on these kids. And these kids with high need to escape, because of these driving factors, also scored very high. Group 4 and DSM-4J is the highest level of pathological gambling. And they also showed a comorbid, if you please, addiction to drugs. Mainly the females in the sample. The males are mainly the gambling sample. But the theory was supported rather systematically throughout. There's another statement that is even more positive, also in your notes, that the model shows a strong path from both the physiological and the emotional predispositions to a deliberate need to escape to severity of gambling. Thus, gambling severity was empirically, independently, found to be caused by the need to escape or dissociate, which is fueled by aversive physiological and psychological states. Gambling, therefore, according to the model and the theory, is a solution, or a coping response, albeit a negative one, to these aversive life conditions and the feelings of distress that they produce. So what we see, again, is addiction as a problem-solving method, the best the addict can find, given what resources he has at the time. So people make the best choices they can, given their resources and the circumstances they're in. And that is no different for addicts than it is for the rest of us. You saw that? You saw that? You saw that? You can memorize this if you wish. But the results of this independent study lead us to evolve 3 theorems, 3 principles. And they are these. 1, indulgence in the chosen substance or activity provides the addict with a ready escape. That's the synonym. You talk about addictions, you're talking about escape. Escape from an unpleasant reality, both internal and external, and both present and past. So it provides the addict with a ready escape from stressors and entry into a rewarding dissociative state. That's theorem 1. That's what we found empirically, in direct support of the theory. Secondly, what the addict does is not the problem, not his problem. It is not his problem. We see it as a problem. It may be a problem to his loved ones. It may be a problem to his employer and so on, but it's not the addict's problem. For the addict, it serves as his best solution for escaping his underlying problems. And the underlying problems, again, refer to those predisposing factors. The third theorem is pretty straightforward after this. If the alcohol is not the problem, if the gambling is not the problem of the pathological gambler, what's going on? He's using that as a means for escaping his underlying problems. Therefore, abstinence-directed forms of treatment, which are directed to stopping the addict from doing what he's doing, stopping him from pursuing his own form of self-treatment, are antithetical, at least to the addict's aims. Very often in the back of the addict's mind, as he sits in your consulting room, he's saying, okay, Doc, I'll listen to you, but your treatment better be better than the one that I've been using all around. Now I want to shift, and I need a technician. Oh my, high-level technician. Thank you, Ken. I want to quickly show you some additional support of the theory. Remember we talked about kids who felt inadequate and kids who felt ashamed and kids who felt rejected and walked around just blue all the time. And my question, of course, was how come? And so I developed the second handout that you have, that screen for looking at early childhood trauma. And I used that with many populations on an experimental basis. And I got the following results. This is what we're going to look at now, the incidence of childhood trauma among pathological gamblers, alcoholics, and drug addicts. And again, we find very similar kinds of backgrounds in these different kinds of addicts. The tool we use is the one you have before you. I won't go into any detail. You can look it over. It's the first tool that not only operationally defines each form of trauma. Unfortunately, the literature and clinical interviews are kind of open-ended and too general. Have you ever been sexually abused? And the person says yes or no. Well, what's he talking about? What's going on here? So we've taken care to operationally define each form of abuse, and I'll show you that in a moment, and you'll see it in the document itself. And the second thing we've done here that goes beyond what we find in other attempts to assess early childhood abuse is to systematically gather a history. And that's the 10 questions that follow an affirmative answer. And we do that with each form of addiction. And that's very important because now you have some structure in back of the very fact of the person having experienced this or that kind of trauma. The structure includes the usual, where was it, how old were you, additional age periods where you were experiencing this threat, how serious was it, does it affect your life now and to what extent, who was the perpetrator, where were you located, what was your living condition at the time, how did you feel about it then and how do you feel about it now? That's a very important question. And the last question that we dealt with in this instrument was I don't want to distance myself from you, just from the microphone. Thank you, Tim. The last thing we looked at is very important, and that is what were the positive factors? What were the possible supportive factors in this terrible situation you experienced as a child? What was the response of your family members to it? And please look. Can you hear me? All right. I'm drawing closer. Now can you hear me? You're very much concerned. I'll try to get too close. We're very concerned about the family reaction because this kid who's been just so devastated, if he doesn't have a positive family reaction to kind of offset the abuse and the aftermath of abuse, frequently taking the form of what? Strong abuse with dissociation leads to what? It's a formula. Strong abuse, experience dissociation at the time of the abuse, 9 times out of 10 leads to what? Post-traumatic stress reaction. And that's a critical concern in treating addicts, because a good many of them, of course, are also, in addition to whatever problems they have associated with a particular addictive behavior, they are also, and in addition, suffering from post-traumatic stress. And if you don't treat the latter, he's going to relapse again. It's something else we've been missing, contributing, of course, to our rather abysmal relapse rates across almost all programs. And there are some wonderful exceptions. I heard about one of them, but they indeed are the exception. I won't talk more about the instrument. You have it there. I hope you not only study this, but use it. Please use it. Because one area that has been sorely missing in the assessment of addicts is the systematic assessment of their early childhood, what we call aversive reactions, aversive experiences. You will see here, if you look at your handout, the operational definition of each term. What do you mean by loss and abandonment? This is what we mean when we say loss and abandonment. This is it. Did you suffer this? Yes or no? Here's the operational definition of neglect. This. So that the subject knows what you're talking about when you ask the question. And so it is for each form of abuse. Who were the subjects in this? Well, we had several groups, small groups. These were early trials, and I alert you to the fact that they were trials using relatively small samples. I did none of these, by the way. These were colleagues in this country and Canada who collected the data on an instrument that preceded this one. It was called the Neglect and Abuse Protocol. It didn't have the section on loss and abandonment. That was added 2 years later. But the studies will show you neglect, abuse, various kinds of abuse as well. These were the subjects. Some male and female pathological gamblers, some First Nations folks from Canada, male and female, some female alcohol and drug addict patients, and some juvenile substance abuse patients. These kids, average age 14, were in a residential treatment center, short-term, somewhere between 3 and 6 months. And one must realize that when kids are put in these institutions, they get what treatment they can, but at the end of the treatment, where do they go? Back home. Back home. And if the home has been abusive or neglectful, they don't want to talk about it. They've been told. What happens in this family stays in the family. And worse, if you talk, I'll kill you. The results were quite startling. Again, I assure you, these are small samples. This is an investigative kind of reporting. What we find was 80% of the adult male and female pathological gamblers reported at least one of these 5 kinds of early childhood aversive experience. We found that among the First Nations, it was even higher, 100%, 88% of these. And among the female alcoholics, it was about 75%, and it was somewhat lower, I think 47% among the juveniles, but remember, their responses were somewhat depressed by their concern about revealing what happened at home. Now, some may say, well, wasn't that psychological amnesia? They didn't remember? Not much. I think the better guess, although it might be both, but the better guess is that they just didn't talk about it. Didn't feel they had to admit it. 2 things will happen if they admit it. The first is going home and getting beat up. The second, if they admit it in many states in the United States and Canada, then a social agency is called in and the parent is arrested and carted off to jail. And so here we have insult adding to the injury. Now the kid doesn't even have a parent involved, the abusive parent. So that's why I think they were rather subdued in their responses. I won't go into too much detail looking at the differences in the genders. By and large, the females are better victims. They always have been. And they're also better reporters of what has happened to them in their complaints of either physical or psychological problems. The thing I want you to watch as we go over these findings are 3 columns. Number 1, the multiple forms of trauma. not only repeated traumas of a given kind, which also occur, but multiple forms of trauma, different forms. 80% of the cases in this group. I also want you to look at emotional abuse. Remember we talked about that yesterday. And this dominates the memories of these 40 and 50-year-old addicts. Not sexual abuse, not physical abuse, not neglect, but emotional abuse. But look at the high scores on sexual abuse among addicts. And not only among the female addicts. What surprised us was the very high scores among male addicts. Population samples that we have, and they're rare and limited, indicate that maybe a little less than a third of women have been sexually assaulted, abused as children. That's devastating. And about half of that, about 1 in 6 males. Well, these figures are much higher than that among addicts and their sexual abuse. And that continues. Here we have another group of pathological gamblers. These are Caucasians as well. And again, multiple forms of trauma are quite high, 56%. We find emotional abuse very high compared to the others. We find sexual abuse, again, extremely high, particularly for the females, but also for the males. That's easily over twice what we'd expect on population samples. And the same with the female finding. Again, look at emotional abuse. And finally, here's a new thing to be watching for, dissociation during trauma. And we ask the question we'll find in the assessment tool. While you were being abused, while you were experiencing this abuse, each one taken separately, which of these dissociative reactions did you experience, and to what degree? It's just amazing how these 40 and 50-year-old addicts remember in exquisite detail the way it was with that day. Not because they have phenomenal memories, but because those kinds of things become frozen, actually frozen, like macedons in the ice, just as they happen. All the attributes are right there, captured. And those of you who've worked with trauma might sometimes be overwhelmed by the fact that when these things emerge, when the client begins to talk about this, these adult clients, 40, 50 years of age, begin to speak of the trauma in the voice of the child who experienced it. The First Nations group, they get beat up pretty bad in their reserve and reservation situations. And we have very high scores for both physical abuse and neglect among that group, quite different from the Caucasian samples of pathological gambling. But nonetheless, emotional abuse is still high. Multiple forms of maltreatment, 93% of them report multiple forms. And again, sexual abuse is extremely high for both males and females. When we talk about predisposing factors of this kind, we can begin to realize how powerful this kind of history can be. Remember, these are children. We are all products of our experience, you know. But in a stage-wise fashion, the child abused at 8 shows the reaction in all he does and is unable to do at 10. And the child, still more deficient at 10, uses that deficiency as best he can to deal with the problems of life he meets at 12. And so the impact of this early childhood abuse is not a one-time thing. It magnifies as the child continues to develop and continues to try to adjust at each stage of life until you meet him in your consulting rooms at age 40 or 50. juveniles, as I told you, are somewhat subdued in their responses, although they're in the same directions. Again, we have multiple abuse as the mode. And these are just some pie charts. And now here's a summary. And again, it shows rather dramatically that the reports of early childhood traumas are very high across all the samples. That multiple abuses are the rule. That emotional abuse usually predominates as the most often recalled. And dissociating while experiencing the abuse is tremendously high, showing a median score of about 83. 83, 4 out of 5 were dissociating as children at the time of abuse. And as I told you before, the odds are, the ratios are, 9 times out of 10. Those people who were dissociating as children, that was the only outlet they had. They couldn't fight, they couldn't flee. The only resource they had for coping was to get out of their own heads, to remove themselves from the pain of the situation, from the acknowledgement of the situation, from even the very presence in the situation, looking down and seeing that poor child being abused. An out-of-body experience, frequently reported. When those things happen, they persist. The impact persists in the form of childhood and adult post-traumatic stress reactions. We've seen the dissociative reactions of the adult addicts. And where do you think they came from? We learn these things. Where did they first learn to dissociate as children? While being abused. Dissociation is the product of abuse. If you find dissociation, it's very likely early childhood abuse, and it continues throughout the life of the addict. It becomes his major form of dealing with stress. Again, what do we get out of this? This again is in your handouts. I won't dwell on it. There are certain common features across different classes of addicts. There's a high incidence of early childhood neglect and abuse, a high occurrence of dissociative reactions while experiencing the abuse. Adult dissociators were very likely childhood dissociators. High levels of dissociative reactions among addicts. This is among grown addicts compared to normal, doing the same kinds of things. And early childhood traumas are clearly a risk factor for later addictive behavior. Yes, we've seen that. Now we'd like to change back. I apologize for the speed of this presentation, but since you have so much of this material in your handouts, I don't feel too bad. But we have more to learn. Now I want to bring you to the place where we put this together. We'll take the theory and the research that supports the theory and put it together and move it towards a theory-driven treatment model, which will, I hope, begin to eliminate some of the things we've missed up to now in our treatment programs. And I hope will add to your own efforts in dealing with your clients next time around. Keep going, please. We're going to go right down and pick it up where we left it off after those 3 theorems.
Okay, just
slide
a moment.
42. Slide 42, my friend.
Mm-hmm.
Just keep right on going, Frank. You've got a long way to go. You remember all of this, of course. Oh, a little more. Okay. Remember, we defined addiction as a self-induced. Now you're convinced it's self-induced when you see how dissociation is used as a skill deliberately to carry the addict from the pain of reality into an altered state of consciousness. So addiction is self-induced. Nobody gets hooked. No bottle reaches out and grabs you. No card reaches out and grabs you by the throat or in the water. Those things simply don't happen. Addiction does not reside. Addiction does not reside in any product or in any activity. It is not implicit in any product or activity. To talk of addictive substances or addictive activities is a misnomer, at least, and a serious error at least. Too many people are doing the same thing without ever becoming addicted. That's the field experience, the natural experience. The greatest experiment we have. There it is. Go to any casino. All the people playing the machines, the VLTs, the so-called crack cocaine of addictive products, they're not addicted or never will be. Addiction is a rather unique fraternity. Among gamblers, 1 to 3% of the adults, as high as 4 or 5% of juveniles, but still a very small number. Many more are in trouble, not only with gambling, but with alcohol and drugs and food and sex and work and so on. But they're not addicts. So addiction is a self-induced dependent state acquired. It's acquired. Remember that chart that I showed you about the course, the onset and course of an addictive pattern? I think you have it in your handout. One develops a skill, just like any other skill, a protective skill of addiction. It's a protective device for dealing with stress. Some years ago, there was a big move in the National Institute of Health to call everything a brain disease. Everything's a brain disease. Well, if you need a shortcut, you may consider briefly addiction as a stress disease, as a reaction to stress. And indeed it is. And that's how I include it in the formula. It's a dependent state acquired by a predisposed person. You've got to be predisposed in an attempt to relieve a chronic stress condition. And as you treat your patients by whatever method, be aware of the fact that in your treatment setting, it's unlikely that they will experience the kind of stresses that brought them in, or the kind of stresses they're going to experience when they leave. And when they leave and experience the same kind of stresses, what's your bet that they're going to relapse again? The likelihood is always high, no matter how good they look during the course of the treatment program. And I have often been disappointed as you have. What looks like a stellar response on the part of the patient while he's in the consultant. But not at home as soon as he hits his first big stress. Addictive behaviors, therefore, to summarize, are symptomatic. They're just the symptoms. And unfortunately, much of our efforts and time and expense have been devoted to trying to change the symptoms. In a more frivolous way, I call it tinkering with the symptoms of the addiction. Trying to reduce the amount of doing it. Trying to reduce the times you do it. Trying to reduce how often you do it. Now, in the short term, these attempts at control drinking, control gambling, control this, control that, are fine. And for non-addicts, they work very well. But for addicts, it's trying to mix oil and water, and it doesn't work. If you're going to have an effective treatment program, you've just got to address these 4 things. You've got to address abnormal arousal states. And virtually every addict has it. But don't take my word alone. Ask.
check it out. Check out each one of these things in each one of your clients. Don't make any assumptions. Most assumptions are going to lead you down a false path. The odds are pretty good, but you don't know how it's going to be with that particular addict that sits before you now. An abnormal arousal state has to be addressed. Adverse childhood experiences, if they're reported, have to be addressed. Long-standing depression has to be addressed. If you've got an addict, here's a 100% guess. 100% guess. He's been addicted the greater part of he's been depressed the greater part of his life. He's been depressed as a child. He tells us he was depressed as a child. And when we said, how come? We dug a little deeper and found out that the depression was rooted in early childhood neglect and abuse. That's where depression begins in addicts and continues throughout their entire life course. And you must deal with that in your treatment program. Limited repertoire of interpersonal coping skills. We talked briefly about that. It's a lot of words, many of them, multisyllabic. What does it really mean? It means this guy is an empty bag when it comes to having skills for living, skills for working, skills for getting along with people, skills for controlling his anger outbursts, etc., etc., etc. Remember, we all learned to do these things through our developmental process, from children through adolescence into young adulthood. But we were there. We stayed in reality to learn. What's the addict been doing? Taking multiple vacations from life. Every time he hits his button and runs. Every time he escapes from stress, he's gone. Not only from the stresses, but he's gone from the opportunity to continue to learn how to adjust in reality. And that's why he shows these gross deficiencies in simple skills of living. And again, they have to be addressed. You may say, well, his addiction is cured. Now we set him loose in the community again. And he's not there 5 minutes when his inabilities to cope raise his stress levels, and off he is again in relapse. So good treatment must anticipate that and deal with it as best it can. Here's an object lesson. The finest study ever done on treatment of alcoholics was done by the group at the, where were they? National Institutes of Mental Health, one of the institutes there, on alcohol and alcohol use. And they gathered a group of therapists, trained them for a year, manualized the treatment, so everybody was doing the same thing, the same way. These therapists had had clinical experience for 3 years with 10 patients, hundreds of patients, almost 1,000 in the study, all told. And the patients, about half of them came from an inpatient treatment program. About half had already been in inpatient treatment before they got into these outpatient programs. These are all outpatient programs, all 3 of them. And these are the methods that were used. 12-step facilitation, 12 weeks, each week, meeting for an hour with a therapist. Cognitive behavioral therapy, again, 12 weeks for a full hour, meeting with an individual therapist. And motivational enhancement. And here there were 4 opportunities to meet with a therapist for anywhere up to 4 hours each time. These were the interventions that were made of this group of outpatient alcoholic patients. They started with over 900, and they followed them for a year. First year they got the treatment, and then they followed them the year afterwards, and they looked at the abstinence rates 1 year later. And the rates give us pause. They're not nearly what we had hoped, but that's what they were with the best therapists, the most carefully screened patients, the most formally manualized treatment programs produced these results. with a 12-step facilitation, 1 year later, 24% of this 900 group that were assigned to this, they were equally about a third to each one. 24% of the 12-step facilitation showed abstinence during the course of the 1 year. Far less of the cognitive behavioral group, 15%, and still slightly less for the motivational enhancement group. What about those who had relapsed? These are success rates, and they're commendable. Patient by patient, they're wonderful. The patients who succeeded. That was grand. Their lives were changed for the better, no doubt about it. But simple arithmetic tells us that we also have to invert each one of these figures. If this is the success rate inverted, we have the relapse rate. 76%, 85%, 86%. Such relapse rates are unacceptable. I'm not judging this program. I'm taking them at their word and saying there's much left to be done to improve what we're all trying to do. Many of us using precisely these methods. What about those who were not in this first group? They followed them for 3 years, and they found that over 3 years, about 30% showed some abstinence. But they were drinking these alcoholics every third day. They had a percent of days drinking measure, interesting measure, which is really controlled drinking every third day. This tells us something. It tells us the degree of success of these programs, and it also tells us that we have much to do to improve our own batting averages. An interesting finding parallels this data. It didn't make any difference if the therapist had formal training up to and including a PhD or an MD or a Master of Social Work or whatever, or if they were so-called addiction counselors, recovering people. Didn't make any difference. They had the same success rates. So the better trained did not produce the better results. That was not the issue. They also found, among all these alcoholics, and whatever treatment they were subjected to, those who also attended AA in the community did better, no matter what the outcome. If they attended AA, they did better. In other words, that self-help group in the community is an absolutely essential adjunct to any kind of therapy that we choose to use. An absolutely essential adjunct, whether it's AA or GA or NA or OA, doesn't make any difference. That self-help group in the community is there. And it is essential and irreplaceable for a couple of simple reasons. They're there 7 days a week. You're not. They're there 24 hours a day. You're not. And they have a live person as a supporting individual, a sponsor or whatever, in most cases. And you're not there for that. You're there for 1 hour out of 168 in a week. That's a pretty short lever for consistent change. So, if that's the best that they were able to do with the best people in the best programs, all manualized, following the best procedure for that particular intervention, what were they missing? And that's the question I lay before all of you today. It's the one that's agonized me for many years. What am I missing? Why can't I be even more successful as I want to be? What am I overlooking here? I must be missing something. Because if I included that, chances are I'd improve my batting average, my outcomes. Effective treatment plans, therefore, I recommend to you strongly on the basis of the research and the evidence that we have. Must include these 4 factors. You must attend to the abnormal arousal state, if that is reported by the addict, and usually they will. frequently they say, well, I don't know if I'm hypotensive or hypertensive. They won't use those terms, but they'll describe the condition. Sometimes they say I bounce back and forth. And frankly, I don't know. I've been titrating this so long that I don't know where I am at any given moment. But I know that there's something wrong. I mean, I'm going from pillar to post all the time with my emotional feelings. Not emotional, but my affect. Adverse childhood experiences. Check it out. That's what that instrument is for. You're going to find, chances are, in 4 cases out of 5, that your addict client will report at least one of these adverse experiences. Long-standing depression, it's always there. You've got to deal with that as well. It's always there. You won't find a happy addict when he comes to you. Maybe in the middle of that stage of resistance, he's a happy bear. When he's totally dissociated and living entirely in an altered state. Oh boy, that's great. Highly recommend it if you can get there and stay there. But otherwise, he's depressed. And there's a limited repertoire of interpersonal skills. You just got to recognize that. And that's got to be included as an adjunct to whatever addiction-oriented treatment you have. You also got to build his skills for living. Otherwise, what's going to happen as soon as you leave? Come on. He's down and out. Stress level goes up, hits his button, he's gone. Whatever button that happens to be. I didn't mention yesterday something that's very important to know. Did you know that addicts were all horsemen? Did you know that? Well, it's true. Yeah. Now, they all have a favorite horse in the barn that they drag out right quick when they're stressed. And they leap on this horse and away they go. That's the horse, their favorite horse in the barn. But every addict has a barn with more than one stall. And in each stall is another horse. Chances are of a different color and a different style. He may have a favorite gambling horse, but he also has a couple of horses, one for alcohol, one for drug use, one for food, one for something else. Alcoholics, compulsive gamblers, food addicts, they're not stupid. They are prepared in depth for dealing with stress, and they know that there are times when their favorite form of escape won't be available to them. It may be blocked. It may just not be there for one reason or another. The court may be standing in the way. An injunction from the wife may be standing in the way. Some, goodness knows what, may block their use of their favorite horse. But they've got other horses. Oh, we have a favorite word for that, too. We call it comorbidities. Comorbidities are horses. Horses. Think of them as horses in the barn. Addicts are not multiply addicted. They have a chosen favorite addiction. And within that addiction, they have a chosen form of gambling, or a chosen form of drinking, or a chosen form of eating, or a chosen form of whatever. Not all forms, but a chosen form. They all have their own thing, and they'll tell you about that. But they all have several horses in the barn for emergency use. And know that as you're treating them, because you're going to have to take a look at the other horses as well and alert them that the treatment is going to include them as well. Therefore, if we know all this now, what do we do with it? Well, we package it. That makes sense. We package it into a new model for treatment, which I call a multimodal model. And it's this. Any good treatment program begins with an initial workup. You just don't jump in and say, how do you do, Mr. Jones? We'll start our treatment now. You've got to know more about Mr. Jones before you jump in there. Or Miss Jones, as the case may be. You've got to do a complete psychological and physical assessment. If you're dealing with addicts, they are physical wrecks. They are dental wrecks. They are mental health wrecks. Largely from neglect. So you've got to have a full workup on them. And the workup should include a detailed social history. It's too bad most of us have forgotten how to do a social history. Unfortunately, many of us have never been trained in how to do a good social history. And those coming out of schools now are in even worse shape. They're turning out therapists. They're not turning out people who know how to deal with people with problems. They're just therapists, which is equivalent to your bartender or your hairdresser. They're all therapists. They don't have any other training. They're all therapists. They listen to problems. They're willing to help. We're supposed to be professionals. And so a workup is absolutely necessary. And once the workup is done and you know what you're dealing with, and you know something about the roots of this person's problems, the contributing factors, all the way back as far as you can get into early childhood, you got to look that deep. You got to peel the onion, folks. Addictions are not a superficial kind of behavior, nor do they involve just a superficial part of that individual's personality. They are bone deep. So the multimodal approach integrates. This is not a sequence. These are things that somehow have to be integrated somewhere in the therapy course. Number one, and most importantly, and it's just a shame that this isn't done in most programs today, is teaching your client, who is running from his own stresses, how to better manage his stress other than hitting his button and disappearing. Stress management techniques are a nickel a dime a dozen. You can pick up any book in the local bookstore, and you'll find all kinds of stress management techniques. Running techniques, meditation techniques, breathing techniques, counting to 10 techniques. It doesn't make any difference. Your subject, your patient, your client has to be taught better ways of dealing with stress than hitting his button and being gone. Otherwise, he won't be there for treatment anyway. But unless he is able to somehow contain, even from a count of 10, running, he can't be learning in the meantime. And treatment is all learning. Learning how to do things differently, learning how to undo certain things. But he's got to be there as a student, if you please, to participate in that activity. And he won't be there if he's stressed out. So any kind of stress management, just ask him, when you're stressed, what do? You go for a walk? You listen to music? You take a run? You read a book? What do? Find out and build on what he has. You don't have to start from scratch. This is not a business of creating a new human being. You build on what you got, on his own strengths. Remember, you're dealing with a survivor. He may be pretty well beaten down, but if he's 50 years old, he's lived a long time, and he's survived all kinds of ups and downs and all around on the basis of what strengths he has, not his weaknesses, not his addiction. Find the strengths and build on the strengths, particularly in this area of stress management. It's easy, and it pays off 100%. Keeps him in treatment. If he stays in treatment, he keeps learning. And by the way, that'll modulate some of these arousal states too. He said, well, when I get, too tense, I take a pill, or I drink alcohol. That takes me down. Well, you're going to have to be a little innovative and teach him other ways to deal with that particular kind of stress. And there are, again, a dozen books out there, simple how to do it books, and your own ingenuity that can lead you to how to deal with this addict's abnormal, extreme arousal states without the use of drugs. You don't want to use drugs in treatment of any kind with addicts. In fact, I find that drugs and hypnosis and things of that nature always leave something to be desired, because the addict attributes any change in his behavior, not to what he's done, but to what the drug has done for him, or what you've done through the hypnosis or something of that nature. The addict has to learn that he did it himself finally, and he did something positive to help himself. We have to combine dynamic and cognitive behaviors to deal with these early childhood traumas. And that's more easily said than done, by the way. You got to have some training, some additional training. You're here for additional training. You're gaining some continuing education credits, I hope. Get some more continuing education credits in how to deal with early traumas. You just can't tromp in there because you're a trained therapist and a certified counselor. Forget it. And the fact that you're a PhD or an MD, forget it. These are special skills that are necessary to deal with the unearthing and processing of these devastating traumas. If you can't do it, get someone you can refer the patient to for this part of the treatment program. The patient may need brain surgery too, but you don't do that just because you're the therapist. Do your targeted coping skill training. Just find out what he can do and what he needs to do better. Then make a list and then say, okay, this becomes our work for the week. We work on your anger management or your time management or whatever the case may be in terms of learning how to cope with life a little better in that particular area. That's part of your job. You're not just a one-on-one therapist, you're a coordinator of other treatments as well. You've got a whole life that you're dealing with, not a peculiar condition. You've got a person's functioning that you're trying to change, not a symptom. And then finally, and again we failed in so many programs in avoiding or somehow not following up on drawing in a significant other. A wife, parent, a friend, a sponsor, someone who can form a bridge from the consulting room to the community. Because without this significant other, we're trying to treat addicts in a vacuum removed from the world in which we're then going to send them, defenseless really. And so that bridge is also necessary. And as you bring in the significant other during the course of treatment, they begin to understand how the addict got to be the way he or she is. And the blame game is set aside. And they begin to really empathize with what the addict's going through. There's never been a session I've held like this without somebody coming up to me and saying, I know I finally understand my husband, who's an addict, or my wife, or my child. I never really knew what was going on, but now I understand. And this person becomes an ally in the treatment of that individual, and a very necessary one at that. Let's say we do all of this. We take a deep breath, we say, okay, Dr. Jacobs said this is the way to go, we just did it. And now we can sit back and accept our laurels. Not so fast. What I warned you about, what I cautioned you about a little while ago, if you find that in your completion of the JNAP lies before you, the patients are reporting dissociation at the time they were experiencing distress, you better also bring in a tool to assess the presence or degree or absence of post-traumatic stress reactions, because those may have to be treated as well, because untreated, you're asking for relapse right off the bat. You're only partially treating your patient. So you've got to check that out and see if that's necessary as well. And in far more cases than we've ever imagined, post-traumatic stress is rampant among all kinds of addicts. Check it out. Very quickly, we don't have a whole lot of time to go much further with this. In 5 minutes. All I can tell you very quickly about post-traumatic stress is, I won't go through the physical and the intrusive and the avoidance symptoms. They're available in any simple textbook. Look it up. Get familiar with post-traumatic stress. These are some of the things you're going to find. These are the complaints about post-traumatic stress you'll hear from your patients. When they talk about these things, if they mention any 3 or 4 of these things, chances are these are people who are exhibiting post-traumatic stress. Those are the symptoms they'll complain about. And your treatment strategy is very simple. Identify the roots, and the roots, of course, are in early childhood trauma. Use the instrument I have given you, or some other instrument, which, of course, won't be nearly as good, but nonetheless, do check it out. The therapeutic opening is very straightforward and must come very early. We were discussing this over luncheon. I was at a treatment program in Rimrock one time with a group of therapists, and we were talking about early childhood trauma. When do you address that in therapy? And they said, well, we have a 28-day program, and about the 26th day we broach that subject. And I said, forget it. We don't have time to deal with it. He said, well, we can't deal with it earlier. I don't think the patients are ready for that. They went to their consulting psychiatrist and complained about Dr. Jacobs, who was saying, you got to get in early on this. And he said, the patients felt it was too soon. It was a rhetorical question. They were frightened to get in too soon. Treatment programs here in Canada have used the theory with hundreds of alcoholics and with compulsive gamblers, and they found it to be very useful. They say the clients learn the theory and are encouraged to begin the journey of discovering how their lives fit the theoretical process. What are their predisposing factors? All of a sudden, it makes sense to them, their particular addiction. There's a program that uses all of their staff to address early childhood trauma. And they say this: we found an essential tool for defining the pathology which underlies addiction, which in turn accelerates the recovery process, is discovering some of the roots of the problem. And we help the client identify in their own lives what those roots are. We have found most important that it's not just to explain the model, but give examples of how it works, but guide the client through his own process of identifying their own trauma, their own personal triggers, and the effects it's had on their lives, and find healthier ways of handling the stress of trauma without dissociating. Their last paragraph is very interesting. They say, despite the fear and emotional pain many clients experience when working with early trauma, they generally rate this part of the program as either exceeding expectations or greatly exceeding expectations on their written evaluations of their treatment program. In many ways, we have found that the use of this model has played a major part in starting the recovery process. One more tool, folks, and I wish you well in applying. More on cautions and dealing with post-traumatic stress. Again, read this somewhere else. Understand that trauma work is a dance of evacuation, of digging and finding out the sources of the trauma, the conditions of the trauma, psychoeducation, processing, and integration into a new model. One basic principle you'll find is in dealing with trauma, the thing that the addict has to do most once he finds out about his own life of trauma is forgive. Can't go out and kill those problems or do that to you. The only real alternative is to get it out of your system. You get that resentment out, you get that acid out of the system, and forgive those for what they did. It's an old admonition, goes back many centuries. Recommendations for you treatment providers, and I'll close with this. Include stress management and coping skill training and a significant other in your treatment plans. Please consider that. Use this instrument to help you identify the nature, the source, and extent of early childhood trauma. Learn to combine dynamic and cognitive behavioral interventions to mitigate stresses engendered by early childhood traumas. obtain experience in treating chronic post-traumatic stress, and finally, come to view the addictive patterns of behavior as the addict's failed attempt at self-treatment of his own deep-seated physiological abnormality and trauma experiences. Mental health professionals must systematically address these underlying causal factors before treatment outcomes can be improved and relapse rates reduced. And in all your efforts, I hope I've helped you just a little bit, opened up a few new doors for you to explore. And in all your efforts, I wish you well.